Good morning, everyone. It's the top of the hour. We'll get started. I'm Thea Wagasback in Houston and like to welcome everyone to today's GlomCon session. Today is our Clinical Trials Conference Series, which is a joint venture between GlomCon and NephCure. Before we get to our topic and speakers, I would like to share with you a little bit about NephCure. NephCure Kidney International's mission is to accelerate research and provide effective treatments for rare forms of nephrotic syndrome and provide education and support to improve the lives of those affected by protein spilling disease. And one of the resources they provide is this Kidney Health Gateway, which can help both patients, physicians, family members find different ongoing trials that your patient may be eligible for, so we can help advance our treatments for kidney disease. So today, our title is Emerging Therapies for IgA Nephropathy. Our speaker is Dr. Dana Rizk. She is a professor of medicine in the Division of Nephrology at the University of Alabama at Birmingham. She also serves as director of the Clinical Trials Research in the Division of Nephrology and as a medical director for Clinical Trials Administrative Office, part of the CCTS at UAB. She has a passion for education and is a member of the clinical competency committees for internal medicine as well as nephrology programs. She has been awarded several teaching awards. Her clinical and research interests revolve around glomerular diseases, and in particular, IgA nephropathy. She has served as the principal site investigator on many clinical trials and is part of several multidisciplinary translational research projects focused on the role of biomarkers in the diagnosis and prognosis of IgA nephropathy. Her research efforts have resulted in more than 45 peer-reviewed publications in prestigious medical journals, including the New England Journal of Medicine. After the talk today, we will have a panel discussion with Dr. Rizk. Joining her is Dr. Sreedhar Mandayam, a professor of medicine at the University of Texas MD Anderson Cancer Center and one of my colleagues down the street, so we're happy to have him, and Dr. Andrew King, the Chief Scientific Officer at Chinook Therapeutics. So I will stop sharing and turn it over to you, Dr. Rizk, and we will get started. And please remember, post questions in the chat as we go, and then we will have a discussion at the end.
Thank you, Dia. Thank you for the wonderful introduction. Thank you for GlomCon for this opportunity and NephCure. I want to thank my panelists ahead of time who will be helping me today. Can you all see my slides?
Yes.
Okay, great. And audio is okay so far?
Yes, sounds good.
Hopefully my dog won't start barking in the background. All right, well, thank you all for joining us today. I'm humbled to have that many participants from all over the world. Thank you for taking the time out of your weekend to join. So these are our disclosures, again, mine and my two colleagues and panelists here. And of course, I want to remind you that the data we're discussing today is still under investigation, and therefore the efficacy and safety of these drugs have not been established, but hopefully they will offer potential therapeutics for IgA nephropathy in the near future. IgA nephropathy, as you may know, is the most common primary glomerulonephritis globally. In the big scheme of things, however, it's still considered a rare disease. It affects mostly young people, and the peak incidence is in the second and third decade of life. And a subset of patients have a progressive disease that leads to end-stage kidney failure by about 30 to 45% of patients over a period of 20 to 25 years from the time of diagnosis, which is typically the time of biopsy. There are so far limited treatment options for these high-risk patients. Of course, they have to be on renin-angiotensin system inhibition, whether you use ACE inhibitors or angiotensin receptor blockers. Beyond that, you can certainly try steroid and immunosuppressive agents, but so far the data for those have been associated with some side effects, particularly when we talk about systemic steroids. And immunosuppressive agents, a lot of them have been tested and did not pan out to be beneficial. I would point out that recently Tarpeo or budesonide, which is a localized budesonide, not a systemic version of it, has been approved conditionally by the FDA. And what that means is that the FDA allowed the drug to be available on the market based on the data that showed a reduction in proteinuria outcome with the treatment with Tarpeo. This approval is, as I mentioned, conditional, and the hard outcome of the effect of Tarpeo on eGFR decline will really determine if the drug remains approved or this approval is withdrawn. So what do we know about IgA nephropathy pathogenesis? We now know that it is an autoimmune disease that starts with HIT1, which is an increased level of galactose deficient IgA1. This is considered to be an autoantigen against which the body starts forming autoantibodies. And there are really two subtypes of autoantibodies, IgA subtype and IgG. And we think that the IgG plays the major pathogenic role. Regardless, this antigen autoantibody then form circulating nephrogenic immune complexes that corresponds to HIT3. And these circulating immune complexes ultimately deposit in the kidneys, specifically in the mesangial area, and lead to glomerular injury. And through a cascade of events that include cellular proliferation, overproduction of extracellular matrix, so on and so forth, you have progressive glomerulosclerosis and tubulointerstitial fibrosis that ultimately leads to a decline in kidney function and ultimately CKD, but more importantly, end-stage kidney disease. And of course, all of this happens in the context of a genetically susceptible host, but also probably also in the setting of environmental conditions. So be it something that's triggered by an infectious process or environmental process is not quite clear yet. Since some patients truly have a pretty benign disease course and go on to have stable kidney function for a very long period of time, it's important that we are able clinically to identify early on the high-risk population, because these are the ones that would require a more aggressive treatment to prevent long-term problems. And we've known for, of course, quite some time that eGFR at the time of diagnosis carries a prognostic value. If you're diagnosed with CKD at the time of your biopsy, your prognosis is going to be more guarded. Blood pressure is another known risk factor. Of course, that's true of all kidney diseases, and you need to aggressively treat hypertension in your patients with IgA nephropathy. Another important prognostic marker is proteinuria. And this data has been published now more than 15 years ago by our colleagues from Toronto under Heather Risch's leadership. And they looked at their cohort from the Toronto Data Registry. And time 0 is the time of kidney biopsy or diagnosis. They followed their patients longitudinally and had data on them for up to 15 years and divided their cohort based on proteinuria at the time of diagnosis, but also sustained proteinuria. And what you can clearly see is that the more proteinuric you are, the worse your prognosis in terms of renal survival. And of course, there seems to be quite a step up in your risk of renal failure when your proteinuria is more than 1 gram per day. And this is where a lot of the selection of patients for treatment trials comes from. And that's why we pick kind of 1 gram per day roughly as the high-risk group. Having said that, if you look at the lower proteinuria curves, there also seems to be a separation if you follow them long enough. And that has led to the suggestion that perhaps the goal for proteinuria when we treat patients should be less than 0.5 grams per day and not just 1 gram per day. So if you identify patients with IgA nephropathy, the first step is to make sure they don't have a secondary process, that this is a primary IgA case. So you need to exclude IgA related to viral infections or autoimmune disorders and so on and so forth. Importantly, the guidelines also apply primarily to IgA nephropathy and not IgA vasculitis with nephritis, which we used to call Henoch-Schönlein purpura. So with that in mind, if your patients are diagnosed with IgA nephropathy, you need to institute optimized supportive care. And what we mean by that is optimal blood pressure management, which is quite aggressive, You need to maximally titrate the ACE inhibitor or angiotensin receptor blockers. You need to implement lifestyle modifications for your patients, so weight loss, exercise, so on and so forth, and address any cardiovascular risk, which includes hyperlipidemia, smoking cessation, and things like that. If you did all your optimized supportive care and your patient continues to have proteinuria, specifically if they have more than 1 gram per day, this high-risk population that we just talked about, then the guidelines, or the new guidelines, I should say, in 2021, recommended considering enrollment in a clinical trial, which was a landmark change from the previous guidelines, and highlight the importance of offering patients ongoing new therapeutic trials. If the patients have advanced CKD and their eGFR is less than 30, the most trials anyway are excluding these patients. But regardless, the thought is here that you have too much fibrosis or glomerulosclerosis to really benefit, certainly from immunomodulating agents. And so for those patients, you may want to consider just maximal supportive care. If, on the other hand, your patient has preserved GFR or relatively preserved, so 30 milliliters per minute or higher, and they refuse to be in a clinical trial, or they don't qualify for a clinical trial for whatever reason, then you should consider the risk-benefit profile of glucocorticoid use. And these decisions have to be discussed on an individual basis. So you need to take into account the toxicity risk from steroids on bones, on metabolic syndrome, weight, so on and so forth. I would point out that these were these data or these guidelines were recommended and published before we had the result from the low testing trial, which was published this year. But we won't go into it today. So today we're going to focus on 2 clinical trials that offer potential therapeutic interventions for patients with IgA nephropathy. And both of these are being developed by Chinook Therapeutics. The first is using BION 1301, an anti-APRIL monoclonal antibody that targets HIT1, so prevents the overproduction of galactose-deficient IgA1. And the second is Atrasentan, which is a potent selective endothelin A antagonist targeting HIT4. So this the last step in this cascade of events. So let's start with Atrasentan. You may have heard about this drug before from your experience with diabetic kidney disease, in particular the SONAR trial that was published in 2019 in The Lancet. And what the SONAR trial did is it took high-risk diabetic kidney disease patients, 3,668 of them, and randomized them after a period of enrichment. So this was an interesting design in wherein they took diabetic kidney disease patients, they gave them open label Atrasentan to see if they, A, will respond by having a reduction in their proteinuria, B, that they can tolerate the drug without having any significant side effects, particularly as it relates to salt and fluid retention or congestive heart failure symptoms. And if patients fulfill these 2 criteria, they were then randomized to go back on either a placebo arm or continue on Atrasentan. Of course, all this was blinded, and patients were followed for a median of 2.2 years. At the end of the study, or at the conclusion of the study, I should say, the placebo arm had an eGFR decline of about 3.1 milliliter per minute, as opposed to Atrasentan that had an eGFR decline of 2.4 milliliter per minute. So a clear advantage to being treated with Atrasentan. There was, this translated into a 35% decreased risk of end-stage kidney disease or doubling of serum creatinine in the patients that responded. The safety profile was consistent with known side effects of endothelin antagonists and was clinically manageable fluid retention. So with these positive results from the diabetic kidney disease, the thought was to then test Atrasentan in other proteinuric kidney diseases. And I'm sharing with you here results that were presented at the European Renal Association in May of 2022 in Paris. So we do know that endothelin levels are increased in patients with IgA nephropathy, and that leads to activation of the ETA receptor, which then leads to a cascade of events and effects really on the vasculature, leading to vasoconstriction and vascular hypertrophy and endothelial injury. It affects podocyte health, leading to cytoskeletal disruption and worsening proteinuria. It leads to tubular interstitial fibrosis, mesangial proliferation and matrix accumulation, as well as glomerulosclerosis, and a slew of inflammatory responses, which of course is deleterious to the kidney. So this perpetuates the cycle of kidney disease and leads to worsening decline in kidney function. In IgA patients, we also know, based on tissue staining, that patients with IgA nephropathy have an intense glomerular endothelin expression. That is particularly true in patients who have high levels of proteinuria. So here are control images, IgA patients that have low urine protein to creatinine ratio, and the ones with high UPCR, you can see there's a marked increase in staining for endothelin. So it stands to reason that if we are able to block the ETA receptor with potent and selective antagonists, such as Atrasentan, this may be a potential approach to treat IgAN patients that are at high risk of progression. So these proteinuric patients right here. So with that in mind, the Affinity trial was a phase 2 open label basket trial, and essentially basket study means that you include several diseases in one trial. And in fact, they had patients with FSGS, Alport syndrome, diabetic kidney disease, but we're gonna, of course, focus on the IgA nephropathy subgroup. So patients were enrolled if they had a UPCR of 0.5 to 1 gram per gram. 20 patients were included, and they received open label Atrasentan 0.75 milligram daily for 52 weeks, and then followed up for an additional 4 weeks. The key eligibility criteria were, again, similar to other clinical trials, biopsy-proven IgA nephropathy that had to be primary, as I talked about earlier. They had to be on maximally tolerated RAS inhibitions for at least 12 weeks prior to screening. Their UPCR was based on first morning void collected at screening, again, with the goal of 0.5 to less than 1 gram per gram. And they had to have fairly preserved EGFR. The primary endpoint we were looking at were change from baseline at week 12 in the urine protein to creatinine ratio based on 2 24-hour urine collection, and the collection, of course, of adverse events to see if it was safe to use this drug in this population. So here are the results. So demographics, nothing surprising. 45 years of age was the median. The patients were well distributed in terms of gender. 50% were women, 50 men. Racial distribution, Asian and white predominantly, which is characteristic of IgA nephropathy, with 2 patients being of other races. Their BMIs were reasonable. They had a median time from biopsy diagnosis of about 3.9 years, good blood pressure control, and their BNP at baseline, again, with the concern about this volume overload that can be induced by endothelin inhibitors, the BNP levels at baseline were normal. UPCRs were about 0.63 from the first morning void, which was done at screening. And this translated into a 24-hour urine protein excretion, so 24-hour urine protein of 1.17 gram per day. EGFRs, the average was 46, and 100% of patients were on either ACE or ARB. So how about adverse events? To date, Atrasentan has been well tolerated. There were 16 events of treatment emergent adverse events, but importantly, most of these were mild to moderate. There were no severe adverse events and no serious adverse. The only serious adverse event was unrelated to study drug. It was a traffic accident, in fact. A patient discontinued study drug because of headache. So in general, there were about 25% were treatment-related adverse events, but they were, like I said, mostly mild or moderate, and no serious adverse event related to study drug were reported. So that's very reassuring. How about volume overload, which again has been a concern for endothelin inhibitors? The weight was monitored pretty closely, and there was really no increase in the mean body weight over the duration of the study. There was no significant elevation in BNP either, no change in systolic or diastolic blood pressure, and there was minimal change in the eGFR acutely after the start of the drug, so only a 0.15 average change in eGFR. So it doesn't seem to have an acute effect, hemodynamic effect at least, on kidney function. So moving on to results, you can see that there was a nice reduction in UPCR at 6 weeks that continued on to 12 and 24 weeks and reached 58.5% reduction at 24 weeks, which is significant. Looking at the data a little differently, you can see that if you divide patients by how much response they've had to in terms of UPCR to Atrasentan treatment, about 91% of patients achieved more than 40% reduction in proteinuria at week 24. And this is considered to be significant. Most studies suggest that 30% reduction and beyond will likely translate into positive hard outcomes, such as reduction of end-stage kidney disease and doubling of serum creatinine and so on and so forth. And this is true of multiple underlying renal disorders, not just IgA nephropathy. In summary, if you will, this phase 2 study with 20 patients with IgA nephropathy that looked at a high-risk population with 70% of them having more than 1 gram of proteinuria per day, but of course, all of them having a high UPCR ratio of more than 0.5. The treatment resulted in clinically meaningful reductions in proteinuria at week 6, 12, and 24. There were no meaningful changes in blood pressure or acute eGFR, suggesting that this was not a hemodynamic effect, but a true therapeutic effect. And it was in general well tolerated, and there was no concern over fluid retention as measured by surrogate markers such as BNP, body weight change, and so on and so forth. So this seemed to be a viable potential therapeutic intervention for IgA patients at high risk of progression. And with that, the ALIGN phase 3 study was launched. That is currently enrolling patients with eGFR of 30 milliliters per minute or higher, urine protein of more than 1 gram per day based on a 24-hour urine collection. And we will see if the same positive results will pan out down the line. So let's turn our attention to the other agent that's being put forward by Chinook to treat patients at high risk of progression in IgA nephropathy. This was, again, these are data that were presented by my colleague, Jonathan Barrett, at the European Renal Association meeting recently. So here we're talking about BION 1301, which is an APRIL inhibitor. So what is APRIL? APRIL is a cytokine that belongs to the tumor necrosis factor superfamily of cytokines involved in B-cell signaling. It drives IgA production and survival of IgA secreting plasma cells and has been shown to increase galactose-deficient IgA1 secretion. In fact, higher APRIL levels in IgA patients correlated with higher galactose-deficient IgA1 levels and proteinuria and lower eGFR. And genetic studies, GWAS studies that showed APRIL gene variants can confer increased risk of IgA nephropathy. So it seems to play a pivotal role, central role in the disease pathogenesis. So BION 1301 is a humanized IgG4 monoclonal antibody that blocks the ability of APRIL to bind to its receptor. And the hope is that it will provide a disease-specific and disease-modifying mechanism to deplete galactose-deficient IgA1, this HIT1 or the autoantigen production, and therefore will prevent the cascade of events that lead to kidney failure. So far, in non-human primates, there was no toxicity observed with the IV form of BION 1301 for up to 6 months. And the sub-Q formulation was also tested for up to 1 month without any significant toxicity. And the drug in a multiple myeloma study was used in large doses with, again, good tolerability and good bioavailability when tested in healthy volunteers in the sub-Q formulation. Because, of course, IV formulation is great, but it's in clinical practice would be hard to implement and much more taxing on patients. So a sub-Q formulation would be much more attractive. This was the phase 1/2 trial investigating BION 1301 in patients with IgA nephropathy. And again, this is an ongoing study, so these are interim results. Cohort 1 included 10 patients that received 450 milligram IV for every 2 weeks, and patients were transitioned at week 24 to sub-Q formulations, and they were going to be followed up for 52 weeks. That cohort has completed its follow-up, and I'll show you the data in a second. And the cohort 2 had 10 patients that were on subcutaneous formulation, 600 milligram every 2 weeks for up to 52 weeks, and this study is still enrolling. And the objectives are to test the safety, tolerability, pharmacokinetic, biomarker effect, as well as preliminary effect on proteinuria. It's a proof of concept, but also a proof of mechanism. And the goal was to explore the dose and the schedule, both in the IV formulation and the subcutaneous formulation. So the patients that were included had to have IgA nephropathy diagnosed within the past 10 years. They had to have significant proteinuria of more than 0.5 gram per 24 hours, or a UPCR of more than 0.5 gram per gram based on a 24-hour collection. Their eGFR cutoff was a little higher, 45 milliliters per minute. And of course, they had to be on a stable and maximized dose of RAS inhibitors as tolerated. These are the baseline characteristics. Mean age 39, 90% of the participants were male. All of them were Caucasians, some were Hispanic, and this was a US-based study. The time from biopsy was 2 years. Again, very good blood pressure control. eGFR was fairly high. Patients had significant proteinuria, whether you look at the 24-hour urine protein per day or 24-hour UPCR of 0.52, and of course, all of them were on ACE inhibitors. So looking at the safety so far, there were no serious adverse events and no treatment discontinuations due to adverse events. 3 patients experienced mild treatment-related adverse events, including 1 injection site reaction. And 4 patients experienced mild infections that were not considered to be related to treatment. From a safety perspective, immunoglobulin levels are monitored, and the IgG level did not have any, nobody had a drop in IgG levels that required the withholding of the study drug, and no significant infections reported for the 1 patient that had a low or significant drop in IgG level. And I'll show you the immunoglobulin data in a minute. There were rapid reductions in free April, which confirms essentially the drug mechanism of action. Nobody develops anti-drug antibodies to date. And the patients, as I mentioned in cohort 1, were transitioned to subcutaneous administration and have had a mean follow-up so far of 22 weeks. So these are the results. In the green curve here is the drop in total IgA level, which, again, a rapid and sustained drop in immunoglobulin A level. But importantly, there was a reduction in this galactose-deficient IgA1 level, the biomarker for the disease pathogenesis, that paralleled the drop in total IgA, and again was sustained throughout the follow-up period. Here is the IgM data. Again, it mirrors what happened to IgA, so an acute drop in IgM that was sustained throughout the study. IgG, on the other hand, was less affected, so there was a drop, but it was much more moderate. And that's important because this is the immunoglobulin G reduction is what correlates mostly with your risk of infection. So from a safety perspective, you don't want to see a significant or severe drop in immunoglobulin G. So how about reduction in proteinuria? This is the data for the UPCR based again on 24-hour urine collection. And you can see that there was a significant and sustained reduction in UPCR over time that seems to be to level off past week 52, but quite significant. So the BION 1301 treatment results in proteinuria reduction within 3 months, which are sustained and continue to decline through 1 year in patients with the fairly severe IgA nephropathy, or at least with a guarded prognosis. 6 out of the 8 patients have proteinuria measurements following subcutaneous transition. Again, here the subcutaneous treatment seems to fare as well as the IV treatment, which is very reassuring. We'll have more data on the subcutaneous formulation in the near future, hopefully. So not to belabor the point, there was a clinically meaningful sustained reduction in proteinuria. There was a rapid and sustained pre-April reduction, which again proves the mechanism of action. Importantly, the galactose deficient IgA1 levels have dropped down, suggesting that we do indeed modify the disease pathogenesis. And there was a small reduction in IgG, which confers safety reassurance. And no anti-drug antibodies have been observed to date. So the next steps are to continue enrollment in the cohort 2 using the subcutaneous injection of BION 1301, and hopefully in the future move on to a phase 3 study. So with that, I would open it up for our panelists. I see a lot of things in the chat, so hopefully we'll have a lively discussion. I'm going to stop sharing and invite my panelists to join.
Very good. Thank you so much for sharing that. I think with the questions and comments that have come in with the chat, it'd be best to start with a couple of specific questions for both of the trials that we just heard about, and then kind of move on to some of the general, how these fit into the general management trials going forward and with other disease therapies.
Sorry, here's my dog.
he's giving you an applause for the presentation. Very good. So first up, there were a couple of questions about the Affinity trial, and Andrew may be able to help us answer some of these. So one question was from Dr. Glassick was about, and it was answered in the chat, but for those that can't read in there, what the Oxford MES scores were for those enrolled. And I think the other point to that is, I know the timeline from the biopsy to enrollment, and if Andrew, you can comment on some of the specifics of that as to how we can interpret to how we're applying this information.
Yeah, happy to respond to that question. We do have redacted biopsy reports for all patients to be able to ascertain the MES criteria from the biopsy. Because of the mechanism of action of Atrasentan, as Dr. Rizk described, having potential to work across different stages of IgA nephropathy, there was no time limit placed on the time from biopsy for entry into the study, just a historical diagnosis of biopsy-proven IgA nephropathy was required, and there were no specific entry criteria relating to the MES score. So anything we can do with that analysis will essentially be post hoc and look for associations. But in a small study, it may be difficult to make too much out of baseline histology characteristics and ultimate responses.
All right, thank you. And then I think that goes to the point too that Dr. Raghavi had made in the chat of, there were some questions about protein creatinine or total protein levels for enrollment. And I think the biopsy question and potentially more information helps with the individual kind of management of the patients. And I think that's where that question then stems from. Another question about the Affinity trial was regarding a pediatric patients, and is there a plan for that? And then in the patient population, the 24-hour urine protein collections aren't necessarily standard or reliable. So could you comment on that?
Yeah, both studies that Dr. Rizk presented required patients to be over 18 years of age to enter, but we do have plans to study pediatric IgA nephropathy with both drugs. Atrasentan is further advanced in its development program in phase 3, and we have already received scientific advice from the pediatric committee of the EMA in Europe and are working towards advice from the FDA on our pediatric study plan for Atrasentan. So while those details are still to be determined, we do recognize that 24-hour collections in pediatrics and the reliability of proteinuria measurements are challenging, and are working with pediatric nephrologist advisors to help define the best way to capture the key endpoints in that study. For BION, being earlier in development, we still have to work through the pediatric plan, but we do think that a drug that has a mechanism of action that targets early in the pathogenesis of the disease in HIT1 may be particularly helpful in pediatric patients to alter the trajectory of disease progression.
All right, thank you. And then a few more specific questions about, now we'll move to the BION 13 based on what's been being asked. And one from Dr. F.A. is about if anti-APRIL targeting plasma cells as well, would you use it with other induction medications?
Yeah, so the mechanism of action is specifically targeted to plasma cells and preferentially targeted to IgA and IgM secreting plasma cells, as Dr. Rizk showed with the immunoglobulin response profile. So far we've seen fairly rapid inductions of proteinuria lowering, clinically meaningful responses within about 3 months that continue to deepen over time in patients with a wide range of baseline severities, from about 0.75 grams to over 6 grams per day of urinary protein excretion. So right now we're really focused on monotherapy to establish the safety, tolerability, and single agent activity. But we do think over time, and Dr. Rizk could certainly comment on this from her clinical experience, there could be the potential for combination treatments targeting different aspects of the pathogenesis, particularly in high-risk patients.
Yeah, thank you, Andrew. So I agree, and there are some questions related to that in the chat that I see, like how long would we treat with BION 1301? Of course, if the drug does prove to be beneficial long term, hard to say. I mean, ideally, you would hope that you could switch off, if you will, the disease, and perhaps you wouldn't need to be on immunosuppressive drugs for the rest of your life. But we don't know these answers yet. We won't really know until these trials are completed. That's probably true of all immunomodulator therapies. It is likely that we would certainly use immunomodulating therapies like BION 1301 on a background of more intensive treatments, non-immunosuppressive treatments that would include maybe an endothelin inhibitor, maybe an SGLT2 inhibitor, likely I should say an SGLT2 inhibitor on top of RAS blockade. There were questions in the chat also about the SGLT2 inhibitors. So yes, I foresee a combination of those. Whether we would use a combination of immunosuppressive drugs, that's also conceivable. So it is possible that we would target B cells, for example, with an anti-APRIL therapy, but we might be using a complement inhibitor or something else in the subset of patients that don't respond to one single immunomodulator. So a little early to judge, to be honest. It's very exciting that we have all these clinical trials. I think they all need to prove themselves individually first as a single agent, and then ultimately we start using them in combination. And to that point, we'd have to make sure that it's safe to use them in combination. So of course, the wider the immunosuppressive approach, the higher the risk of potential toxicity and infectious complications. So time will tell, but nothing's off the table at this point in time. Sreedhar, I don't know if you have any other comments to make.
No, I think I agree with everybody. I think we need to figure out a better way to strategize which patients would benefit from more aggressive therapies. So my view is in probably a few years, everybody will be on SGLT2 plus maybe endothelin receptor antagonist. And then only those that continue to have proteinuria or signs of progression or some adverse risk markers, either galactose deficient IgA level or something, will be the ones that we will aggressively immunosuppress. Coming back to the testing trial that everybody keeps talking about, I do realize that it was wonderful that they use methylprednisolone against placebo, but the occurrence of infectious and other adverse effects was significantly higher in the treatment arm versus the placebo arm. So these are not harmless compounds, and we need to be careful in using them, especially in patients where the risk of progression may not be very high to begin with. So that would be my thought.
Yeah, so Didier, if I may add to what Sreedhar said, so hopefully in the future, beyond the current risk stratification strategies that we have, which is, biopsy, proteinuria, eGFR, and blood pressure, we would have specific biomarkers that would then direct us to use a non-immunomodulator for this particular patient, or maybe intensify what we call conservative care, which in the future will include maybe an SGLT2 inhibitor, endothelin inhibitor, so on and so forth, and identify the subset of patients that really have an immunologically active disease that will require maybe, moving to an immunomodulator from the get-go. We don't have that kind of granularity or precision medicine yet, but I think we will in the future, in the near future.
And do you think that those will be, serum markers, urine markers, with the Kidney Precision Medicine Project? There are lots of things that we may be able to do in the future on the biopsy. Where do you kind of see that future going?
Yeah, I think a combination of both. So biopsy markers are great, but they're usually one snapshot in time. It's very hard to really, obtain tissue repeatedly. We may repeat the biopsy. I mean, we do it in lupus patients. We're much more reluctant to do it in other GNs, but that may or may not be the right answer for these patients. Serum for sure seems to be more advanced in terms of developing assays for biomarkers. And the urine is being explored pretty aggressively because it's the easiest, of course, biospecimen to have access to, and it's in unlimited quantities too. So I think it'll be a combination of all of the above. Kevin, you had a question?
You should be able to unmute now, Kevin.
Okay, thank you. Yeah, thanks, Dr. Rizk. I had enjoyed your presentation, and a question for you and actually Rebecca Cook, because I noticed that she's on there from NephCure. But the one thing that I guess I'm trying to hear your thoughts on this, because you're involved in a lot of these different clinical trials, is that there's all these IgAN trials that are moving forward, right? And so it gets harder and harder to recruit for these trials. It costs the sponsor more and more money. And, I know Meg Jardine has talked about these adaptive trials, but has there been any discussion to try to figure out how to make this process more efficient with all these different trials coming? Anyway, just curious your thoughts on that. Thank you.
Yeah, no problem. I give you my own personal opinion. I don't know that there have been discussions, and maybe Andrew has, the sponsored perspective. In my practice, there's always nuances between the trials. So I try to kind of course, guide patients to the studies that fit their profile best. So it could be as simple as a GFR cutoff of, 45 versus 35 for another study or something like that. But more globally and on a philosophical level, with the limited tools that I have, if I feel that I have a young patient that has an active kind of aggressive immunologically an inflammatory type of picture, so lots of hematuria, recurrent gross hematuria episodes, things like that, those in my mind, I would favor giving them immunomodulating therapies. Do I have scientific proof for that? No, but that's my personal approach. As opposed to the population of patients that have, yes, proteinuria and are at high risk of progression, but may have had the disease for 10, 15, 20 years and are likely now dealing with the secondary effect and the glomerulosclerosis and tubular interstitial fibrosis. So to Andrew's point that he made earlier, these in my mind fit perfectly an endothelin inhibitor, for example. And so not to say that we shouldn't include kind of like a broader population, we should, to get more answers, But if I have multiple competing studies, I help the patients also make a decision because it is sometimes hard. The other thing to keep in mind is, of course, the side effect profile. So, concerns over volume overload in a particular patient that has significant proteinuria and is already having edema, maybe not the best endothelin inhibitor patient. There are concerns over spermatogenesis with endothelin inhibitors. A young patient may not want to take that chance. Infectious complication, as Sreedhar mentioned, in the subset of people, for example, that refuse to be vaccinated. These are not hard. Again, there's no hardcore science behind it. This is the art of medicine more than anything else. But I help patients from that perspective select the best trial for them.
And you mentioned hematuria, and Dr. Soler had asked about the role of hematuria in clinical trial and clinical trial design and disease activity. And is that something that is taken into consideration? Should be. What are you Sreedhar, thoughts on that?
No, I think that's a wonderful thought. And when I was in fellowship, it used to be very, very important to keep an eye on hematuria. And then over the last 5 to 10 years, proteinuria has taken center stage and people don't talk about hematuria anymore. So I think that we now, a renaissance is happening for clinical trials in nephrology and glomerular disease. So all of these wonderful questions that Dr. Glassick and everybody else are asking, we can now answer them. Can you actually measure A or B and see what it does to correlate to treatment response or prognosis? We did not have the data sets and we're building them. So it is wonderful that it is happening now. So my perspective as against Dana's, I have patients that come from all over the state. And so to me, since we don't know one medicine is better than another, I actually leave it up to the patient and their convenience. So we now have the ability to give an IgA nephropathy trial drug once a month, once a week, once in 2 weeks, pills, whatever it is that they would like to choose. So until I have conclusive proof that one is better than the other, to me, it is truly patient choice and their convenience. And I'd like to put in a plug for diversity. I mean, when I look at the study sites and the number of subjects, my heart sinks is usually 100% Caucasian or somewhere 90% above. So I think that if we make these trials more accessible to people, to community nephrologists, to community sites, then we will have more representative patients in the studies. And so we can go back and talk to our patient in front of us saying, this is what is the chance that this medicine will work for you. Rarely do I see a sponsor spending a lot of time thinking about it from the patient's perspective when they design clinical trials. I'm hoping that that will change in the future.
Yeah, I think it has, and there have been a lot of effort to decentralize clinical trials as well for patients that like to do that, to get home health visits and so on and so forth. To your point about hematuria, we don't, anecdotally, we talk about hematuria and so on and so forth. In clinical trials, it hasn't been standardized to use hematuria even for prognostic value. Part of the challenge with hematuria is the fact that if you collect urine at the site and have to, transport it and send it to whatever central lab, really the value of red blood cell counts, or anything like that goes down significantly because these red cells either lyse or are not preserved. And so it's a much more tricky biomarker. I do agree. I think a lot of us feel like it's an important biomarker, but we have not been able to kind of standardize it to be able to use it in clinical trials to our advantage. So locally, when we have access to urine microscopy, we run down the hall and do a urine sediment check and stuff like that. That's extremely valuable to give you an idea about glomerular injury. So yeah, I can't. It's amazing. I mean, I'm impressed with the.
Well, I think one thing. Yeah, we have. There's a lot of questions. We'll try to get to as many as we can. I think one thing that I would like you guys to comment on is it's been brought up as the SGLT2 inhibition, and one of the largest IgA sub-patient populations was in the DAPA-CKD So how do we, Dr. Glassick made the point of, is it standard of care right now that we should be using SGLT2s with RAS inhibition? How do you look at that, and how should we be thinking about these trials that are ongoing if we're going to be potentially recommending this as a baseline therapy? I think that's a key point that we probably should discuss and get your guys' opinions on.
So the DAPA-CKD, as you mentioned, had a large subpopulation of IgA patients. The post-hoc analysis from that trial suggested that SGLT2 inhibitors do play a protective role. They had a significant impact on proteinuria in the IgA population and also renal outcomes. The patient population in DAPA-CKD was a little sicker than you would expect from your typical IgA patients. There was a higher percentage of patients that had diabetes. I don't remember the exact number, but relatively high percentage. A larger percentage also that had congestive heart failure. So it was also older population. So not your typical IgA population. The other caveat is there was everybody was on RAS or ACE and ARB, but there was no effort to maximize ACE and ARB treatment prior to enrollment into the trial. So with these caveats in mind, I think the SGLT2 inhibitors certainly seem promising in non-diabetic proteinuria kidney disease, including IgA nephropathy. I think the AMPA-CKD trial that's going to be published, the results at least will be out hopefully in the fall of this year, would potentially seal the deal whether we should use SGLT2 inhibitors in IgA nephropathy patients. It is not standard of care yet. Although I will tell you that patients now come in and ask for SGLT2 inhibitors. It's not always available either. Insurances are not covering it yet because it's not standard of care. So in the future, it may become part of the armamentarium. And I think a lot of clinical trials are taking into account the fact that this landscape is changing. And so patients that want to be on SGLT2 inhibitor can, it's not required for entry into any current study. However, again, you have to be on a stable dose to be able to participate, because if you introduce any variables, any new medicines that affect proteinuria, then you're also affecting the outcome of this trial in a negative way. So you either are on it prior to initiation of the study, or you can't really just drop in and start it in the middle of the trial because it'll affect your outcome.
Thank you. I think you said all the points that I think we all need to hear as we interpret the results and apply these going forward. And with, like we said, and like Sreedhar said, lots of new things coming out that we hope that in the very near future we have a lot of answers to all of these questions. There were some questions about APRIL levels and elevation, and is that something that's measured, and how, if you could comment a little bit more on how that's done from the drug effect, and is there a sustained discontinuation of the drug? What is our kind of thought, or do we have any data on after a year what we may see with that?
Yeah, so we do measure APRIL routinely in these trials for the BION 1301 program, both at baseline and following treatment. In the literature, APRIL is reported to be significantly increased in IgAN patients relative to healthy controls, although there is significant overlap between baseline APRIL levels. And so far, we haven't observed that baseline APRIL levels predict the response to BION 1301. We get a fairly consistent reduction in IgA, irrespective of what the baseline APRIL concentration is. So far in IgAN patients, we haven't experienced drug discontinuation and long-term follow-up to see what happens following chronic treatment with BION 1301 to the recovery of APRIL or galactose-deficient IgA. Will be really interesting once we get to the part of the study to evaluate that. But we have in healthy volunteers, after only 3 doses of BION 1301, discontinued BION 1301 and followed long-term the recovery. And it does occur. Ultimately, IgA levels and APRIL levels do return to baseline following 3 repeated doses of Bion 1301. But it's really interesting to study this novel biology, and we'll continue to get additional insights as the program advances and ask some of these questions like the sustained response following drug discontinuation.
Thank you. And then there was a question about the serum level of galactose-deficient IgA, and is that a predictor of prognosis compared to, or do we have any information on looking at that compared to the International IgA Prognosis Tool Score and what that takes into account?
Yeah, that's a great question. So thank you. I think Dr. Glassick raised that very important point. So galactose-deficient IgA1 levels have been correlated with outcomes. There is no data whether they add to the known poor prognostic factors such as blood pressure, EGFR. The blood pressure and EGFR, I would say yes, but MEST score and the international Rizk score, no, not yet. So the data, a lot of it was generated before MEST score was standardized and available, but these questions are being investigated. And so, yes, it would be great to find that Gd-IgA1, galactose-deficient IgA1 adds to the prognostication, which is what I kind of alluded to earlier, being a little more specific in risk stratifying these patients, upfront, hopefully in the near future.
Very good. And we're almost back to the hour. So to be respectful of everyone's time, if anyone else has any last questions, please type them in or feel free to raise your hand and we can ask directly. And then we're really excited for all the engagement we've had and tried to get through many things, but an exciting topic and hope for a lot of new developments.
So Andrew, maybe you can, in the last couple of minutes, comment. There was about the endothelin inhibitor effect on spermatogenesis. And then I had the question about galactose-deficient IgA. I know I'm a panelist. I'm not supposed to ask you a question, but I will. Whether the galactose-deficient IgA1 decline was above and beyond the total IgA decline. So meaning, did you look at the ratio of these two values, or was it just the mere fact that you reduced total IgA?
Yeah, so to the first one, there is a class effect of endothelin receptor antagonists on the potential to impact spermatogenesis in preclinical toxicology studies, as well as a couple of small clinical studies have also showed the potential for ERAs to decrease sperm concentrations in some patients. So it is an important consideration as part of the informed consent to enter the trial, to be informed of the potential of this class effect of these agents. In terms of galactose-deficient IgA, for Bion 1301, we typically see that they largely have a very similar trajectory, total IgA as well as galactose-deficient IgA, although the magnitude of depletion of Gd-IgA1 appears to be a little bit deeper than the total IgA pool. So on average, we're seeing about 65% reduction in total IgA at the mean level across all patients, compared to about 75 to 80% in galactose-deficient IgA. So whether that's meaningful or just a small sample size at this stage, we'll continue to follow.
Also, just to add, I think Otsuka has a much larger phase 3 going on for a very similar compound. So we should be able to get some really useful information when those trials, it's just started, so it's probably a few years out before we get anything from them. So
Thank you. Well, we're back to the top of the hour. So want to thank everyone for joining. Thank you, Dr. Rizk, Dr. Mandayam, and Dr. King. And thanks everyone for their participation in this session today.
Yeah, we really appreciate it. Thank you. That was great.
All right. Bye, everyone. Have a great rest of your day or evening.